Welcome, Martin.
Thank you very much, Alexandra. As usual, fantastic presentation, Didier. I'll pick up on some of your points as well as I go through. And to give you some background on myself briefly, I'm an infection control nurse for about 30 years standing now, although I now work in industry. And so I do need to make a declaration. So in addition to my recent experience working in the health service in the NHS Nightingale Hospital in London, I actually am clinical director of Gamma Healthcare, who generously donated myself and my 3 colleagues back into the NHS because we've all worked in infection prevention for some time. And they gave us back to the NHS at this critical time because definitely there's an issue with depleted infection prevention and control teams. So I'm grateful to them. So the problem, well, in London, the modelers were suggesting that hospital services were likely to be incredibly overwhelmed with the number of cases. And we had the same, as it turned out, modeling over projection. And as Box said many years ago, all models are wrong, but some are useful. But there was a huge potential for the NHS to be completely overwhelmed, given that the number of patients who were actually being admitted to hospital were likely to need respiratory support. Now, in the UK, we have a low number of ICU beds per capita compared with the rest of Europe. I think we have half as many as Italy and a quarter as many as Germany. And we also, in the capital city, have quite a few older hospitals. We have some new hospitals, we have some older hospitals, in which the oxygen requirement was actually difficult to provide. So it was decided in government levels there was a need for extra capacity. And so 7 extra hospitals were built around the country in Birmingham, Bristol, Exeter down in the West Country, Harrogate in the east of the country, London, Manchester and Washington. But only one of these was all intensive care units, and that was the London Nightingale Hospital, which was built in the Excel Centre. So that's an exhibition centre. Some of you may have been to it in the east of London, and it has 2 enormous halls. If you've been there, it's about 600 meters long. Basically, it's composed of 44 exhibition hall modules in 2 long halls, and that was decided to be the best place to actually set up this hospital. So the good thing about an exhibition centre is that it's a big space, and so on the 21st and 22nd of March, the military planners went down to the hospital with some NHS England to look at the potential of the facility. And the army are used to setting up field hospitals. They have plans to do this, not in an exhibition centre, obviously in the field, but they worked in close conjunction with British Architects, BDP, and they designed the hospital, although that design was very much a moving feast, and I'll come back to that point later on. We were often having to change and modify designs. The staff to run it were actually going to be a volunteer workforce because London hospitals were already short-staffed, but we were trying to get volunteers in to take part in this, and I'll come back to that point when I come to the cleaning staff. But within 10 days, the hospital had been built, and the facility was formally opened at the beginning of April by the Prince of Wales, Prince Charles, via a video link. Although interestingly, he probably could have come because he'd actually had colon virus quite early on. So our first patients were admitted on the 7th of April, and thankfully, London just about managed to cope, and we were placed on standby by the 6th of May. So the unit is still there, but I'll come back to that as we go on. Now, to look at the build, when you walk into one of these rooms, I can tell you when I first walked through the door and joined my colleague Annette Jeans, who was the infection prevention lead. She'd been there a day before me. When you walk in and see the size of these enormous halls, you wonder how on earth this is going to happen, because you're looking at 600 meters by about 100 meters wide, and this is just going to be one huge ward area. But the good thing about a conference center is it has all the facilities there to build a shell scheme, and that's effectively what was done. So we were able to build the shell scheme, and I'll give you an idea of the layout in a moment. But over a period of 10 days, the hospital emerged. So we had 42 bedded wards, if you like, or units, with services running down the middle. We had to bring in oxygen. As you can imagine, in an exhibition centre, there is no normal need for oxygen. even though some people may gasp at the new products that people are showing in these areas. Generally, the oxygen is there, but not for patients who are going to be ventilated. There's no water, there's no drainage in the middle of these areas, so we had to think about all of those issues. But at the end of 10 days, what pretty much looked like an intensive care unit actually emerged from this. You'll note that the flooring was a bit eclectic because they were just bringing in rolls of whatever they had. So I'm sure somebody might think, oh, this is a fantastic design. Somebody spent a lot of time over that, but it really wasn't. It was just somebody handing you the next roll of floor covering and putting that down. So I'm going on to the next slide just to give you some idea of the scale of it. So each ward area was designed in blocks of 3. So we used Bedford ward in the main. There was Bedford A, B, and C. But here we have the purple, blue, green zone. In total, we had 14 ward areas of 3 on each side of the unit, with a central boulevard going down the middle that was responsible for doing all the supply. So we came in through the middle, and all equipment and staff went in through the middle. Staff came out to the middle, but the dirty went out of the back side. And I can give you an example of that in a moment. And in each of these 3 ward areas in the block, there was a space also down the middle that people could move around. And this really was designed to help people cognitively, in that it was all exactly the same, so there would be no cognitive overload. And actually, if you go back to Scutari and Nightingale's original hospital design, that was based on work done by Brunel, where he felt that staff, if you're setting up quickly, you have to be familiar with the surroundings. So that's what they were able to do. So huge challenge, because we just had these 2 big rooms, which are 12 exhibition halls on each side. There's no hot water at all. It's just cold water, very limited drainage. There's certainly no toilets, and in fact, there were no showers. In fact, when we turned up, there was actually only 1 shower on the whole site. It's not something that they would normally use. And we had no oxygen. And you can see in the picture on the right-hand side, BOC, British Oxygen Company, came in and set up an enormous oxygen facility. And then the pipework went down through the floor and up under through the car park and back up through the floor in various sites. We had problems with logistics. Well, not problems, the challenges with logistics, and so different companies would come in and assist us with that, and they would be responsible for getting hold of our PPE. And that sometimes was a problem for us, because sometimes we would have PPE coming in from different sources. So the size of the gown would alter, the design of the gown would alter, the quality of the gown would alter significantly. So one day you would have extremely high quality surgeon's gowns, the next day they maybe weren't quite the same quality. We had problems with sizing of gowns as well. So we had a large batch coming from China, which was small for China. Well, small in China is definitely not small in the UK. So there were a number of challenges in that aspect. And then for staff, the challenge was possible in this unit. So they were divided into blocks of 4 or 6. And so an intensive care unit nurse would oversee 4 or 6 patients, with somebody at the bedside who may be just a registered nurse, or sometimes a junior doctor, or sometimes an allied health professional, or sometimes a dentist working at the bedside. One staff group we utilised extremely well, and they were fantastic, were the operating department practitioners, who of course are well used to dealing with anaesthetic and ventilator equipment. They're also well used to positioning patients as well, and their skills were really useful in that unit. And I'd urge other people to look at that staff group if you have those available. Another challenge was PPE, making sure we had the right amount of PPE, and the procurement department always managed to source just enough PPE and drip fed through to us to keep my blood pressure at a high level every evening, when we were counting them every evening. Thankfully, we had all the same masks, which meant, and I'll come back to masks in a minute when we look at doing the fit testing. Now, I mentioned we were going through the central boulevard into the ward area, and to ease flows, we had corridors built so you could push a trolley with clean equipment into the trolley, into this small corridor, and the staff would transfer to effectively a dirty trolley and take it into the main unit. Getting out the other side, of course, there's no waste facility in this area. We had to build a corridor, which was effectively our dirty corridor. So all of the clinical waste went out of the back of the unit, and things either went as clinical waste or as sharps. For human waste, what we were doing was solid waste was going into the yellow bags, and the liquid waste, the urine, was actually solidified with a gel and again placed in the clinical waste, because there was no facility for disposing of human waste in the facility as well. So we had to do that, and we had some areas for the cleaning staff to dispose of their cleaning fluids as well. Now, going on to PPE. Because this was an all-intensive care unit, it was classed as an area in which aerosol generating procedures were performed. And according to Public Health England guidance, that means an FFP3 mask, which then meant, because of our regulations for health and safety, we had to do fit testing for everybody, and we had to bring in outside contractors. And there was a problem with that, because most hospitals don't have the fit testing capability to do this regularly. But fortunately, in industry, in the construction industry, there are a group of fit testers who regularly do staff for things like asbestos removal or people working with silica dust. And these fit testers were available to come and support us. And we often had 4 or 6, even 8 of them on site at any one time, able to fit test the staff. Fortunately, we always got exactly the same FFP3 mask, which then meant we did not have to keep changing or refit testing people. Now, other PPE that everyone was wearing was the fluid repellent gown, and we used a pair of surgical gloves as a base layer. Our visors we were reusing because they were of reasonable quality, and we felt we could wipe those and leave those in the clinical area. Staff would work a 2 days, 2 nights shift pattern. So we would give people a visor when they first arrived on their first day, and they would use that over the 4-day shift pattern, and that didn't cause us any problems at all. The logistics of getting staff in and out then of this area, we had to model quite extensively. And when we looked at what we had available originally, there were some small walkthroughs into the halls. They were really not going to be particularly useful. You could only get 3 people in donning and maybe 4 people in doffing areas at any one time. And when we looked at how long it would actually take somebody to put on the PPE, it was going to take over 3 hours to get a shift into the unit. So that really clearly wasn't really going to work. But what we did have at the entrance to each hall was a large shutter area. And so the shutters would normally go up to let vehicles in and out. So what we did was we actually brought the shutter most of the way down and built rooms. So we roughed it out on drawings and had, again, a relatively small donning area, because doffing is more critical, because that's when you're removing contaminated clothing. And these were built within a couple of days, and we put fans on them to make them pressurized. So even then, though, that still didn't give us quite enough time to get everybody in. And getting the message over about PPE was also very important. And actually, this was a very nice picture drawn by David, one of our donners and doffers. We had a donning and doffing team to help people make sure they were safe when they were going in and check that their PPE was all appropriate, but also to support them when they're removing the PPE, just to remind them about removing things in the correct order. And David drew this very nice picture based on our acronym. We were saying BFG, which is body, there's the gown, the face, mask and hood, and then the gloves. And he drew the nice Quentin Blake style picture, which actually, when I put that on Twitter, Quentin Blake's group gave it a nice like, so we're very pleased with that. We continued to modify procedures over a period of time, and actually, once the number of patients got up around the 30 to 40 mark, you needed a lot of staff in at one time, because you had the intensive care doctors, you had anesthetists there, an intubation team. We had a turning and proning team, because a lot of our patients were proned a lot of the time. We had a cleaning team, then there was all the cleaning staff as well. So there was a lot of people going in during the shift. So we actually moved out to these donning pop-up areas, and actually we were able to get a shift into the unit in 17 minutes, which we were really quite satisfied with. You'll see on the middle table there, we've got bits of tape with specific colors. We were trying to think how we could identify staff in this area, because everybody's wearing exactly the same PPE, from the cleaning staff up to, right the way through all the staff groups. And actually, we used colored tape on the shoulder to designate who was wearing what. So, for example, the intensive care unit consultants would have 2 red stripes on their shoulder, and the nurses would tend to have yellow stripes on their shoulder, and the other doctors would have green stripes on their shoulder. And that seemed to work quite effectively when you were trying to find somebody in quite a hurry. One key message we really did need to get over was that the PPE you were putting in to go into the area wasn't your PPE for protecting the patient. It was the PPE just for protecting you. But there was a tendency for staff as they were putting on the PPE to think that's their PPE for the day, which really wasn't the case. So your visor protects you against the droplet, your mask protects you against the aerosols, your gown protects your uniform, and your gloves protect your hands. Well, when we were then going to the bedside, of course, the patients are still at risk of other healthcare associated infections you would normally see in an intensive care unit. So we had to go over to the fact that actually the gown they were going in and the first layer of gloves was actually going to be their skin and their uniform. And then when they got to the bed, they were going to have to put on an extra apron if they were performing a procedure that involved a lot of patient contact, and another pair of gloves. And then we had to change those gloves when going from patient to patient, so that to protect the base layer of skin. So my mantra is this PPE just protects me. So cleaning, big task. We've got something that's 10 meters high, is an enormous building. We had lots of inexperienced staff. A lot of the staff who came to work in the cleaning teams had never done any healthcare cleaning at all, because the people normally working in healthcare cleaning were still obviously cleaning their hospitals. And I have to say, ISS were absolutely magnificent. They brought in a lot of inexperienced people. They did a lot of training with them. They gave them the why you need to do it, which is always critical. So rather than just focus on the task, they told them exactly why they needed to do the task. We had people from all walks of life in doing the training who'd never even worked in a hospital, let alone an intensive care unit. One thing they found very useful was having an operational manager inside the unit at all times to be able to go around and talk to people and sort out their problems. Other problems we have was, of course, they're wearing two layers of PPE. They're wearing their base layer, and then they're wearing an extra PPE to do often quite physical tasks. So there's the risk of dehydration. And that was one of my concerns, I have to say, at the beginning, because when people go in, they're often into 4 to 5 hours, and they were tending not to drink very much because they were worried about coming out to the toilet and not having to completely doff and then re-don again. And in the first few days, we found staff coming out with headaches, which is a real giveaway for dehydration. And so we had to assure them, you must drink a lot, because you are not going to want to go to the toilet. You're going to perspire this out. Other issues we had, because of wearing the PPE, communication was a little bit more difficult to get messages over, and we had problems with getting access to the bedside when the bed was occupied, because often there were a lot of people around each bed, which actually meant that the bedside worker had to undertake much of the daily cleaning, and they would do this with wipes because they wouldn't have access to the cleaning equipment that the ISS staff did, and the trolleys and that sort of thing. But that seemed to work very well. But honestly, I cannot praise ISS enough, because the communication we had between everybody was absolutely fantastic. In fact, that was one of the best things about this hospital. It was an extremely flat structure. Everybody was in the same team. We all worked together extremely well. Another thing I wanted to pick up on was staff welfare. So this next slide you're seeing here is the ISS designed sort of garden area outside. Unfortunately, the weather wasn't that brilliant all the time, but they set this up for scrubs, issue and reissue. So we had no training facilities for staff. We had to build that outside. Staff would collect their scrubs, go into the hospital, and then come out and change their clothes again before they were able to go away. We did build some showers there for staff as well. But staff welfare was absolutely critical, and there was always people from the staff welfare team waiting outside doffing to speak to staff who sometimes were coming out quite upset if maybe their patient hadn't done as well as they'd hoped. So we had a big staff welfare team in working with all staff who were often working in extremely difficult situations, and we had boards up saying, what are the problems and what can we do about it, and chances to write that up. There was actually an app also developed for people to give feedback as well, so that was absolutely critical. Just going on to another slide, one thing that was difficult was the social distancing. And in the early days, we did actually get transmission of COVID in meetings where people were sitting too close together. And it was almost as if staff felt they were fine when they were in the clinical area, but when they were outside, they didn't worry about it quite so much. And you'd see maybe 4 doctors on 3 steps of an escalator going down, when you'd say to them, well, actually, what's about the social distancing, chaps? Actually, I did speak to one group before, and their answer was, oh, we've all had it. To which Murray's response was, well, I'm not really surprised if you're standing that close together. But actually, people have to act as role models as well, because we're expecting other people to adhere to social distancing as well. Ultimately, we were lucky. We actually only had 54 patients who were admitted to the unit, even though we were ready immediately to take 200 and could easily have expanded up. But fortunately, London just about managed to control it in time, and the rest of the hospitals, by hugely increasing their isolation capacity, were able to cope. And 63% of patients actually left the unit alive. So that showed that the actual standard of care we given was on a par with any intensive care unit. So that was really quite reassuring that the modelling that we put in and the standard of clinical care from the medical and nursing staff was really on par with everybody else. The flat structure, I think, was really helpful. If you made a decision, it happened extremely quickly. Changes were very easy. Everybody had a voice. Everybody could talk to everybody. You would listen to everybody, and that was a really key thing. When people are telling you things, you listen to them. Listening to them, there's a huge amount of learning went on. For me, the education and training are absolutely critical, and that's where I think clean hospitals can really help with the training of people, because it's all right giving people a task, but when they understand why they're doing something, and that's one thing that ISS drummed into people, this is why you're doing it. When they get why, then they're far more likely to do it well and effectively. The best thing for me about the hospital, I think, was that everybody was in the same team, and this was repeatedly stressed. So the hospital is now being closed. It's effectively mothballed, because we're certainly not going to be using the XL for anything else for a little while. We're ready we're all on 72 hours callback, should we be needed again. So we're ready to go. We will, over the period of time where things are a little bit quieter, review our procedures, think what we can do better. So yesterday in the O2, there was a big learning event where the staff were able to give feedback on what worked and what didn't. But I'm really thankful to Gamma for allowing me to go, because this was a unique experience and possibly one of the most interesting and stimulating and challenging experiences in my clinical life as I'm getting to the end of my clinical career. Anyway, thanks, Alexandra. Happy to take any questions now.
Very much for the really fascinating presentation, Martin. So I'm just waiting for the question mode to come up. Okay. So could you, 1 second.
While that's coming up, I saw one question about quantitative or qualitative fit testing. Actually, we did both. So we did the qualitative fit testing first, and if people failed that, we would try the quantitative method. And often we did have the equipment for that because we brought in the contractors, and often they would pass that. If they failed that, then we had some reusable masks we could try them with, because they a small number, and for some people, like in anaesthetists, we had a small number of powered hoods as well.
Very good, thank you. How do non-medical people behave toward employees and volunteers working in this new building? Is there an atmosphere of support, or did you notice any negative behaviors?
No, I noticed no negative behaviors. Everybody felt that they were in it together, and everyone was talking to everybody. I saw no negative behavior. It was just one. It was right from the word go, from the first day, it was stressed. We are all one big team here. And everybody got the same PPE. Everybody got the same form of training. Everybody was of value, and I didn't see any negative behaviours at all in this unique atmosphere, I think.
Very good, thank you. So, facing COVID-19, what have we learned about healthcare and hospital design? And do you think that we need to rethink hospital layouts?
Certainly, we're going to be looking at our layout, because we had these 42 bedded block wards. But one thing we did find that was challenging was often there wasn't enough space at the bedside to maybe prepare for an IV. So we're looking at maybe thinking about modifying the design slightly, so we would have smaller blocks of beds then with a utility area. And so, some of the other Nightingales, I went to the Birmingham Nightingale, and they actually had clinical rooms designed into that. We didn't have that facility, unfortunately, but that's something we could modify going forward. So I mean, I certainly wouldn't advocate the design of the Nightingale in a normal hospital, because the whole place is just open. So we had to treat the whole area as an aerosol generating procedure area. But I think when you do this sort of thing, it's good to have a really good reflection about actually what really did work and what have we been doing for a long time that really we probably didn't really need to do, or other things that we weren't doing that maybe we really should do.
Thank you. What challenges did you come across concerning the human part of implementation with healthcare workers and environmental service workers in this particular situation?
Okay, well, that's some work that's ongoing, but certainly from the experience I've spoken to people, everybody found it really stimulating, very interesting. They were delighted to be part of this completely new venture. I know I speak to some staff, some general nurses who went in. They're now thinking about going for a career in intensive care unit because they had not worked in intensive care units before. Other people are thinking about changing career. I spoke to one of effectively a supervisor for ISS, who's now thinking about moving into healthcare now because she enjoyed the experience so much. So I think people got a lot out of it because the management team put a lot into them in terms of training and support.
Thank you. Did the cleaners wear the same PPE as you were describing for the healthcare workers?
Yes, because it was an aerosol generating procedure area, everybody wore the same PPE.
And has the quality of available supplies concerning PPE, masks, etc., been an issue?
We got all the same masks, which was a blessing. The gowns were a variable size. I think quality-wise, they were okay. Actually, we did, as Didier said, you have to think about, are we going to have to reuse? And I got some nice work from Mark Rupp in America, looking at potentially for using UV on masks should we run short. We did actually launder some gowns. So when we thought things may be quite tight and we couldn't get an assured supply, we had some gowns. When I got the materials data sheet for them, they were a spun lace type of material that would take 130 degrees. So we felt they would probably go through a washing machine. So we did wash them 3 times and test them for water repellents, and they held up at 3 times. So actually we washed quite a few of them and just the once and put them into store should we need them again. And we did have to use them once or twice when the only gowns we got coming through were extra small. So we were able to reuse these gowns, and actually they were more comfortable because they were conditioned, as it were, and we had no problem with that. It's not something I would routinely do, but I think a little bit more work can be done in that area going forward, because if you get the materials data safety sheet, it'll give you some indication of whether you may be able to do something. And the Infection Prevention Society and the Central Sterilising Club got together and produced quite a nice document about considerations, what you should be thinking about if you're going to potentially reuse PPE.
Very good, thank you. We're starting to run out of time, but we have 3 more really good questions that I would like to share. So how many cleaning operators were there per patient about, and how many people from ISS were working there?
Do you know what? It seemed like a lot, but I couldn't give you an exact number. I do know that originally, right at the beginning, we had far too many cleaning staff going in, actually, because they staffed it for a few hundred, and then we ended up with about 40. So we had to cut down the number of cleaning staff going in. But I couldn't give you the number of cleaning operators per patient, I'm afraid. I could probably find it out from my ISS.
Thank you. Did the patients wear masks?
No, all the patients were ventilated. So they came to us after they'd already been put on a ventilator for 2 to 3 days in a London hospital, and they had no more than 1 organ failure. So the patients, this was an only intensive care unit hospital.
Very good, thank you. And how could we make sure that this hygienic behavior and these improvements will last after Corona?
Really good question. I mean, I'm a great favor in the expression "never waste a crisis." And people have definitely changed behavior. Hand hygiene compliance rates have gone up enormously. And I think it's maybe we have to work with that. What's in it for me? People maybe think of hand hygiene to protect themselves. But it would be very interesting to see if other healthcare infections have maybe stayed the same or gone down during this period. Because we often report hand hygiene in the UK as 98%, and I don't believe that it is. But when we were doing audits, we were getting 60, 80, 90% compliance, genuine compliance. And it was easy for us to do an invisible audit, if you like, because everybody's wearing the same PPE. So nobody knew that you were actually watching hand hygiene. So I think hand hygiene and other environmental behaviours, some hospitals have been ringing a bell and everybody cleans the surface close to them when they hear the bell ring. It's almost like Pavlov's dogs, but it's a simple behavioural thing to do. Ring the bell. Everybody does the same thing. Maybe we can embed those sort of behaviours, because I think there is an opportunity here to build on what we've done with coronavirus.
Great. Thank you so much, Martin.